Hello everyone. I am Dr. Bhupesh Patel from Asian Super Specialty Hospital, Navrangpura, Ahmedabad. Today we are seeing the videos of posterior cervical endoscopic lamino-foraminotomy. He is a 55-year-old male with severe right arm pain and not able to lift his hand and move, and with weakness on the right upper limb. So on MRI you see the C5 C6 right paracentral foraminal disc herniation, and there is a very well stable facet joint and very well stable segment. So we are planning endoscopic posterior cervical lamino-foraminotomy. So once you mark under CM the junction of lateral mass and the facet joint, lateral mass and lamina. So when you see the endoscopically, it's the same view. You see that there is a V junction here, the superior lamina, inferior lamina, and its adjoining lateral mass. So the V junction, this very V junction, you have to identify on your endoscopic view. If you identify till you make with RF the make a space, and once you identify this V junction, then the things is very easy for you. Just you start drill that junction till you remove the 20 to 25% of lateral mass. Superior inferior lamina you have to drill. You have to drill from clockwise, counterclockwise. You start from drilling 10 to 11 o'clock position to 2 o'clock or 1 o'clock position. So drill gradually, see how much you have drilled, because the lamina here is very thin, and if you drill, if you apply a force with your drill, then you might injure the nerve root ones, and your drill might go the very thin ligamentum flavum, because here the ligamentum flavum is very thin, and sometimes it's very sometimes it may be absent. So in this position, if you drill without taking extra care, you might injure the nerve root. So you have to be very careful. Any soft tissue it's encountered during your approach, you have to carefully remove with the forceps or RF that soft tissue, so that your vision does not get obscure. And any bleeder during your approach, if you encounter any bleeding during your approach, you have to carefully coagulate, because if bleeding become excessive and sometimes you don't coagulate enoughly, then bleeder vessels might get retract and you didn't find the end of bleeder. So throughout your surgery, this bleeding keep public, and you might get obscure your view, and you sometimes you had inadvertently remove too much bone, or you may damage the nerve root. Again drill till you get satisfied your endoscope can go inside, and you will find that lateral edge of the ligamentum flavum and some vertical membrane is going from above and downwards. If you identify this vertical membrane, the root is just below that vertical membrane. Remember, the ligamentum flavum again is very thin in foraminal area. What we find in lumbar spine, there's a ligamentum flavum is very thick in the one extension of flavum goes to the transverse process and SAP. So but here it's not happen. Ligamentum flavum is foraminal area sometimes very absent or very thin, so you might injure the nerve root. Here in approach, if you find that you have to drill the pedicle to in order to reach the axilla of traversing nerve root, you can drill the pedicle, because the cervical spine stability is not that much issue, because the cervical spine has to bear weight of head only. So if you are drilling a little bit of pedicle, it's allowed, but it's not allowed in lumbar spine. Again, you have to drill very carefully, so that you don't go anywhere, and constantly keep your view in the mind. Here you can see the joint is very well appreciable at around 7 o'clock 5 o'clock position. You can see the joint, so joint should be all the time in your view. You have to be very oriented while drilling. So drilling is the most important part of posterior cervical lamina-foraminotomy. So here we are doing little bit of laminotomy, that's why we are drilling a little bit of superior inferior lamina. But when you want to do only foraminotomy and foraminal disc, so you just need to drill the junction and the facetal mass only. No need to drill the lamina. Here we have a big disc in the paracentral and foraminal area. So here our scopic angle is around 25 degrees. So you can see the paracentral disc here. I am using the transforaminal scope for posterior cervical endoscopic foraminotomy. Again, once you drill completely and you find the space below the lateral mass, then you can use the Carrison punch. Once you use the Carrison punch and carefully remove this fascia, I am talking about this vertical fascia, so you have to cut carefully. So once you cut this vertical fascia, you will find the nerve root below that fascia. You see, now. And this fascia sometimes carries a lot of bleeders, so you have to be very careful, coagulate first, and then you just remove that fascia and that its adjoining blood vessels. Again, for to reach the shoulder part of the root, we have to drill little bit of more superior facet and lamina. So clear your view very well before removing the disc, because if you don't remove enough bone or don't create a space and then you try to remove the disc, you might not remove, you might retract the root excessively, and many times here there is no space, and instruments where what you are using, you need to be very small instruments, so instruments sometimes may not able to remove the disc. You see the now ligamentum flavum, and now from the shoulder I am just trying to retract the nerve root, if whether I can retract or not. Sorry, not shoulder, from axilla. I am trying to remove the retract the nerve root from axilla. You can see, yes, I find the fruit fragment. So I got the fragment. So with your dissector, you have to just tease out the fragment under the axilla. So when you tease out the tease out the disc material, herniated material, you will very well remove that disc herniation. So this is, sorry, I was on the wrong impression. This is the axilla, and I'm now just trying to remove that flavum on the upper part with Carison. You have to be very careful while removing that part, because this flavum might be attached adherent to the spinal cord. In cervical spine, there is a spinal cord. There is no dura, no root. So you have to be very, very careful, and you cannot take a chance while because once you damage the spinal cord, patient might end up with a weakness. You see again, second fragment we remove from the axilla. It is also very big fragment. Again, I am trying to tease out. I am going more to the more centrally towards the paracentral area. So I remove the foraminal fragment first, then I remove one fragment from the paracentral, and now I am going more medially. Here with the dura you can go more medially. So again I am teasing out the fragment. You can see the third fragment is coming out from that area. Yeah, very well appreciated. And I'm sure in cervical spine, this is the most rewarding surgical procedure, endoscopic foraminotomy, because 95 to 98% people don't have any recurrence, and 100% pain relief. People will become very happy, because the disc in cervical spine volume is very less as compared to lumbar volume, so recurrence chance is almost negligible. You can I'm just exploring the shoulder, whether I can remove any fragment. Yes, I found one or two fragment in the shoulder also. So always explore the shoulder and axilla both. Never because many time if fragment is high migrating to foraminal area, so you cannot remove that fragment from the axilla. You have to remove that fragment from the shoulder. So you see there is big fragment, and this fragment has vascularity. So that means this is a very important fragment for pain to get relieved. So if you just explore the axilla and not exploring the shoulder, you can see the vascularity of that fragment. So if you just explore the axilla and don't explore the shoulder, many times there's chances you might miss that fragment in the shoulder area. So now our root got completely free from shoulder area. You see there is nothing is left in the shoulder. Again, you can see that directly reach out to the disc space. So my dissector is now in the disc space also. So again I'm trying to see any remaining loose fragments. I'm just now there is no fragment, so I'm just coagulating with the RF. So now axilla and shoulder are both completely clear. There is no leaf left fragment is available remained. So completely free nerve root, both area from shoulder as well as from the axilla. There is not even single trace. So root is completely free from above and down. So it is very important in cervical spine to respect the cord, respect the nerve root, don't stretch too much, and stretch under vision. Again, the advantage of endoscopy is magnified view. So even you retract, you see in endoscopy retraction is too much, but in real spine, in real time retraction is not that high. So there is a completely free nerve root. Okay. So thank you. I'm just removing little bit of garrison just to get more space over the axilla, but it's completely free now. There is nothing left inside, and everything is completely free. So I'm just removing this membrane just to get more vision over the shoulder area. And but now the root is completely free. We just do the little bit of RF, and so getting more clearer view of the axilla and shoulder. Thank you.